Ready for your shoot.
So let me just take a moment to introduce. This is Gaston Murias from Buenos Aires. Gaston is a critical care specialist, director of the intensive care unit. What hospital? Did I know?
Clínica Santa Isabel.
And he's going to talk about Amato's recent paper that was published in the New England Journal of Medicine that did a detailed retrospective analysis of a bunch of the lung protective randomized controlled trials that seemed to imply that driving pressure was the primary variable that affected outcome.
Well, thank you very much. It's a real pleasure for me to be here. I will spend, I hope, no more than 20 minutes in this. I hope we could have a discussion. The history of the deep history of protective mechanical ventilation starts in February 5, 1998, when Marcelo Amato published the first randomized controlled trial showing that the given mechanical ventilatory strategy could improve mortality in ERD patients. In less polite words, it could be expressed as a guy's optional misuse of mechanical ventilation was limited. 2 years later, also in the New England Journal of Medicine, the big study of the NIH confirms that doing in one way is not the same to do in another way with mechanical ventilators, and that mechanical ventilators could improve or impair mortality of ARDS patients. The conclusions can be summarized in just 2 lines. Use 6 milliliters per kilogram of predicted body weight, and choose PEEP from this table, taking into account oxygenation parameters. So huge was the enthusiasm for this time, at this time, that even a usually very critical member of our community, like Martin Tony, says that it was the culmination of an era in the research on the acute respiratory distress syndrome. But what we really knew at the end of this era, we knew that 6 milliliters kilogram was better than 12, and almost nothing else. In fact, we didn't know if 4 were better than 6 or 8 were better than 6. And we knew nothing about PEEP because both arms of the study were treated in the same way. I would like to review the acknowledged mechanism of ventilator-induced lung injury. The first of these is overdistension, when respiratory cells strain during inspiration. The cell membrane stretch, increase its tension, and is exposed to a distension force. When this distension force is quite low, nothing happens. When it's too high, the cells broke and die. And in the middle can trigger an inflammatory response that is first local and then could be a systemic inflammatory response and affect the results. Fortunately, this mechanism is quite limited because most of the lung is folded during expiration, and most of the increase in volume is accounted for unfolding more than stretching of the structure. The second mechanism is shear forces. In 1970, Sherman, in a mathematical model, predict that the tension in the walls of alveoli that are in the boundaries of closed alveoli but are already open is very high. In fact, he calculated that this tension could be equivalent when this gland is inflated with 30 centimeters of water, could be the equivalent to this homogeneous lung inflated with 140. For the same reason, it's very unlikely that this can be a mechanism. Because why these alveolus could remain closer with such amount of forces trying to open it? And finally, we arrive to the star of the ventilator-induced lung injury, that is the open and closing phenomenon. I would like now to discuss this. I would like now to focus your attention in an old paper from 2001 that, in my opinion, is highly underrated. The authors sent papers, ARDS patients, to the CT scan, and they studied the behavior of open units when they, in a stepwise fashion, they download our pressure, and the behavior of the closed units when, in a stepwise fashion, they increase airway pressure. What they found is that both opening pressures for closed alveoli and closing pressure for already open alveoli have a range and a normal distribution. And also, what they found is that the mean difference between the pressures that can open a unit and the pressure needed to keep them open is 16 centimeters of water. The maximal frequency of closing pressure is 5, the maximal frequency of opening pressures is 21. Does it matter? I think so, because each tidal volume acts as a small recruitment maneuver. When airway pressure increases during inspiration, you can open units that are closed, and when pressure decreases during expiration, those units can or cannot remain open. So maybe you can approach driving pressure as a recruitment maneuver. Each tidal volume is a recruitment maneuver. In fact, these authors, Bone and co-workers, found in a very smart study, they randomized rabbits to one of two ventilatory strategies. One of the groups were under high-frequency oscillatory ventilation, and the other was under conventional tidal ventilation. Eventually, the others performed recruitment maneuvers in both groups. And what they found is that those rabbits increase lung volume in response to recruitment maneuvers, and those rabbits do not. And why they do not? Because all they were able to recruit was already recruited by tidal volume, by tidal recruitment. I beg your pardon, is in Spanish, the mathematical model, I cannot transmute. Based on creative data, I made a mathematical model to analyze the behavior of open and closing alveoles. In the left, the model is loaded with Crotty data. These, in fact, are exactly the histograms they actually found. And what you can do in the right is to modify PIP and driving pressure to understand what is happening inside the lab. If you increase PEEP level, you modify the total amount of lung that is collapsed during expiration, during inspiration, and the result. The result is the higher from both, because if you don't have enough inspiratory pressure to open units, they will remain closed. And if you don't have enough PEEP to keep the units open, they will be closed. So the other thing that the model can analyze is the amount of opening and closing. As you can see, PEEP do not produce, the reduction of PEEP do not produce opening and closing. PEEP decides the total amount of lung that could be closed or open, but not the open and closing phenomenon magnitude. What about driving pressure? If you increase driving pressure over the 16 value in having fluctuated loaded, of course, it appears that opening and closing phenomenon is started. Why? Because during inspiration, you open units that you cannot keep open during expiration. So, in each tidal excursion, you have open of units and closing of units. And Marcelo did it again 1 month ago. He published a new study that is one of a kind, you know, because it's not a clinical study, but it is also not a meta-analysis technically. What he do is a pool of data and an analysis as treated, not an intention to treat analysis. And I think both points are very important to explain the results. I'm sorry. Up to Marcelo paper, tidal volume, or his replacement, or how we use it? Sucedáneos?
You're using proxy or surrogate.
Surrogate. Driving pressure was treated as a non-continuous variable. They labeled high or low, but they have no a continuous variable to analyze. When you do a pool of data, what you have is that different designs provide you with different target volumes, both for the lung injury and high injury routes. But moreover, if we go to the patient room to set up a tidal volume, and we are intended to set up a 6 milliliters per kilogram of tidal volume, we will not set up all the same value. Small differences in the measurement of the patient, rounding of calculated values, and the actually volume we finally set up will account for a range of tidal volumes instead one single value. And we can expect that those values will have a normal distribution. Hopefully, the more frequent value will be the target value, but there will be a range of values below and up the zeroed value. So if you did an as-treated analysis instead an intention to treat, you have even a more continuous distribution of the analyzed variables. And then you have, in fact, an artifact that could allow you to set a real cutoff point between the different values. And what did Marcelo found? only two elements predicts mortality. One of them is driving pressure, and the other is Apache 2. Neither BT nor PIP, only driving pressure. And what he found also is that the cutoff point, the value that divides the good values from the bad values, is 16 centimeters of water, the same value that in the Crotty model explained the starting of opening and closing units. And what about PIP? There is an acknowledged problem with the PIP work. While clinical evidence has failed to demonstrate any beneficial effects of PIP, experimental literature is very consistent, and in each model you can find PIP has a protective effect. So this difference that have been trying to be explained by designs, issues, and so on, it's an acknowledged difference that we have not explained at all. Should PIP reduce the opening and closing phenomenon? Maybe not. In a high PIP scenario, you can expect to have a huge amount of lung open and a small amount of lung closed, and a band that is opening and closing between inspiration and expiration. In a low PIP scenario, you can expect to have less lung open, more lung closed, and the size of the band at a glance should be the same. What we can expect is to modify the position of the band, but not the size, at least at a glance. Alejandro Brun is working in Santiago de Chile, and he kindly lent to me this graph I show you. What Alejandro did is to send his ARDS patient to the CT scanner. And instead to use the CT scanner to perform a whole thorax scan, they placed the CT scan in a fixed point of the thorax that is 2 centimeters above the maximal excursion of the diaphragm during expiration, and perform many readings along the ventilatory cycle. So he can analyze the behavior of the opening and closing phenomenon. In black, you see the non-aerated tissue. The non-aerated tissue is higher during expiration, lower during inspiration, and the magnitude of the change is the magnitude of the opening and closing phenomenon. As you can see, the most important determinant of the open and closing phenomenon is the BT. When you increase from 6 to 12 the tidal volume, you can see a huge increase in the magnitude of opening and closing. But, as I cannot expect from my model, when you increase PIP, you can see also a noticeable decrease in opening and closing. I went back to my model, and once again, when I tried to produce changes in opening and closing with PIP, nothing happens. But if you set up a driving pressure that is over the safe value, now when you change PIP, the green bar, the opening and closing bar, did change. And why is this? Come back to Crotty data. If you set up the driving pressure at this point, all the units you can open are units that you can keep open during expiration. But what about if you set up a driving pressure that is higher than this maximal value of driving pressure? You open during inspiration many units that you cannot keep open during expiration. So the area of this curve accounts for the magnitude of the opening and closing phenomenon. And what about if you increase speed? If you increase speed in this scenario, this area fall down. Why? Because the amount of units that needs so huge pressure to be open is quite small. So, if you modify PIP level, could or could be not be an increase of opening and closing. And so we can explain from this model this difference. While the experimental papers have been done using a high driving pressure, injurious mechanical ventilation, all the clinical papers have been done using protected mechanical ventilation, I mean low driving pressure. Until Marcelo papers, conclusions were easy to learn. Use 6 milliliters kilogram of predicted body weight and choose PIP from this table based on oxygenation parameters. But I would like to be speculative and a little bit provocative now, and start my conclusion for the near future. I think in the near future we will determine the maximum driving pressure suitable for our patients, and if not possible, maybe we can use 16 as an initial approach. And more important, we will not decide PIP without regards of driving pressure. If you can keep driving pressure low enough to be in the safe values, in the safe zone, you should better use the lower levels of PIP that you can use to handle hypoxemia. But if for any reason, for instance, the patient have also an acute brain injury, and you cannot down the ventilation, and you have to have a driving pressure higher than 16, then I would use the highest PIP level that the patient can tolerate. In the meantime, I will keep ventilating patients with this approach, but I would use the driving pressure as a new stop rule. So I will use 6 milliliters per kilogram of predicted body weight unless the driving pressure for that is higher than 16. If so, I will down tidal volume as needed to keep driving pressure in the safe zone. Thank you.
So then you may be happy to know what we do in the medical ICU here. So Amato's analysis, you probably know, has been out there for about 10 years trying to get through peer review, and it was no secret among the critical care community, this delta B, and the cut around 15 or 16 centimeters of water. So back during H1N1, we developed a PEAK worksheet for our medical ICU, and one of the columns we put in there was driving pressure. So I guess I'm saying we agree.
maybe we are using that in a non-protocolized way, but we were already using that in a way.
And in a way, and another way of looking at this is kind of a little bit of a way of setting peak based upon best compliance, because the best compliance will be the lowest driving pressure if you keep tidal volume fixed. Right?
Right.
So it may all go back to Souter's paper from a long time ago.
The New England 77.
Yeah. Some people in this room were born then.
Gaston, in which conditions driving pressure will not work? What to do when we have patients with increasing abdominal hypertension, things that...
It's saying that for tidal volume and airway pressure, if your chest compliance is too bad, maybe you can have a higher driving pressure and instead you can be safe. But we don't know which is the highest driving pressure we can use safely. We have no data.
Yeah, this is all hypothesis, actually.
Mm-hmm.
We were in Madrid with Bob a week ago in a meeting that Zlatsky present some new data on this paper, okay?
Mm-hmm.
And because the question is, what should we do, as you do here, to titrate mechanical ventilation according to the delta P, or just stay?
Compliance and delta P.
Yeah, or not, no? And then, since in the New England there is this table that, I mean, you can increase, I mean, there is a table that you if delta P is not changing, you can increase tidal volume, which is dangerous. You know what I mean? Saying that it's
I think
people.
This will be the conclusion in the future. Forget about tidal volume.
But I think that's
If you have a lung that is
Wait.
healthy enough,
Let me finish.
No.
Let me finish. The issue is, so now our highest point in plateau pressure is 30, right? So can we go up to 30? So they split this data, you know, in lower than 30 and higher than 30, and they found that increasing diving pressure, I mean higher than 30, it's dangerous. And now they have 10,000 patients on that. So it seems that, I mean, still we have a high value. So in plateau pressure, where we need to minimize the delta pressure there. And even if the delta pressure it's low, at plateau pressure higher than 30, mortality increases, is what they are now analyzing. This presented that as a non-published data, but they are still analyzing. Bob is around? No, I don't know. Where is Bob? Well, Bob was there. You know, maybe he can complement my explanation. But, I mean, it's nice saying that maybe, I mean, all these concepts of strain and so, and stress.
maybe your distension start to work.
Yeah,
at this
exactly.
point, you know.
Yeah. I mean, saying that even if you have maybe high PEEP, but there is over distension, in some units this could be dangerous. But this is a speculation, mostly for hemodynamics. That's the other point. If we go high in pressure, then we have an impairment on hemodynamics. Let's see what's going on in the high-frequency trials, and now it's gone, high frequency. Nobody's using it, it's finished. I think, yeah, maybe you can establish...
Never started here.
Never started. Okay, no, never in our units, no, we don't know what's high frequency. But now for believers, you know, high frequency, it's gone, you know.
Yeah, so I think, for me at least, a dangerous takeaway from this analysis is that high tidal volumes and high plateau pressures are okay provided that delta P is less than 60. I think that would be the wrong message.
I would never say that at this moment.
But there are some who are. So one of the things we have to remember is that all of the studies that went into the analysis, for all intents and purposes, used lung protective ventilation. So a question is, why in the analysis did not high tidal volume also provide a signal? And the reason is there were very few patients in those studies who had high tidal volume. So statistically, if there's a limited range, it's not going to show up in the multivariate analysis. So there's, I think we have to be careful before we say, well, I would run the PEEP up to 30 and I'd let the plateau pressure be 43 because the delta P is less than 15. I think is without evidence of knowing what the esophageal pressure is and the pleural pressure and so forth. I think that.
I think we do not have enough data up to date to say something like this. But if you take a look to the experimental literature, that can be or not similar at what happened in humans. To avoid opening and closing appear to be far more needed than avoid over the stage.
Yeah, so there are two ways to avoid opening and closure. One is to maintain open, the other is to maintain closed.
Mm-hmm.
So, and I don't think we know, I think maintaining open while subjecting the lung to a high plateau pressure might not be the right answer. We have the evidence from, I think mostly Ranieri's group, that plateau pressures even more than 25 can cause, at least physiologically, overdistension. A couple papers from that group in the last year or so.
Let me think. It's true that in the New England paper of the Amato 98, it is established, I think, in the results and in the abstract, that the driving pressure, it's the important thing that also was the determinant on outcome. In 98, do you remember that?
Mm-hmm.
I can even see the sentence in the New England, because I use that sentence many times because it makes sense. It's what just you said. At the bedside, what we do, we just fix tidal volume and we play with PEEP and see something. I mean, we increase 10 in PEEP and the plateau pressure increases 5. Compliance is improving, dying pressure is lower, and maybe this patient has huge improvement in oxygenation. Then we try to find other things. I mean, data space, and we play around. But what you said, if that happened, it's good. It could not happen, many times. But if that happened, it's good. No, I believe it's important. I agree.
Yeah, I think the other challenge, at least in the medical ICU, that is faced is the potential for recruitment is sometimes not very great. There's a lot of consolidation, pneumonia, and it's not, if it was just a collapse issue, it would make it a lot easier.
Could you help a little bit about if your mathematical model works correctly, if I correctly understand, maybe there is some patients in which the opening and closing phenomena can be even lower if your driving pressure is 10?
Of course.
So maybe it can be another target to go to the less tolerable driving pressure.
Of course.
In case that this is the main
In
problem
fact,
of the patient.
if you look at the Crotty paper, not all the patients have a 16 phase shift between opening and closing pressure. So the best way to use these ideas would be to determine the driving pressure, the maximal driving pressure adequate for your patient. Yes. When you go to the model, this is the same information. You have the histograms, or you have the cumulative curves. And the cumulative curve is the pressure volume curve, as Meyer stated before. So if you go to you can do a pressure volume curve. Not now to set PIP in the fashion Amato did it in 1998, but to set up driving pressure. This elegant curve never occurs. You have the most frequent pressure volume curve is like this. And how to use this information to set up the maximum driving pressure, I think that the answer came from here, from the machine. Jose Venegas in 1998 published an equation to adjust not only inspiratory but also expiratory data from a pressure volume curve. He developed an equation that has 4 adjustment parameters. E is the volume over CRF. B is the total lung capacity. C is the middle of the equation. And D is a dispersion value that allow you to calculate lower and upper inflection point in an analytical way. So C plus 2D is 2 times D is the upper inflection point, and C minus 2 times D is the lower inflection point. So what we can do in an automatic fashion in the ventilator, what ventilators can do is to perform a low flow inspiratory and expiratory curve and calculate C for those for both limbs and state the maximal driving pressure at C minus C prime. And this could be done in an automatic way. So now many ventilators calculate this in one way. That could be a good way to determine the maximal driving pressure allowed for your patient at this moment.
Or the other way of doing this is to display the pressure time curve and try to look at stress index.
And try, sorry?
And look at stress index. So look at the curvature in the pressure time relationship.
I agree.
So,
but you have there information about tidal recruitment and over-distension.
Sure, and that's
But
the beauty of the stress index.
Yes.
So that's because it gives you that information.
But as all the units are seen as a whole, maybe you can have over-distension and opening of the lung, and you can still have, this is acknowledged limitation
Sure.
of the model. No? But of course it can be possible.
Be quiet so you can take the picture.
That's what I asked for silence, you know, to take a picture of Gaston here and with during his talk. So at the end, what we should do?
I would use driving pressure as a new stop rule.
And use the table,
If
the NIH table.
okay.
So which table? Because there are
Maybe.
two of them, right? So there's a more aggressive peak and a less aggressive peak.
In a low driving pressure scenario, I would use the less PIP that allow me to have a secure oxygenation with, say, no more than 50% of oxygen fraction.
So then how do you reconcile that with again, it's post hoc secondary analysis, but the real meta-analysis, which suggests that there's a survival benefit for using more PEEP and the PF ratio less than 200, and may be harmful to use more PEEP with the PF ratio greater than 200, right? So,
to me, you know, after being involved in the prone studies, and not in the definitive one, but in all the preceding studies, in the studies that we use this value of 10 of PEEP 24 hours after a radius, and we nicely, now there is 2 papers, one in British Medical Journal, one in Critical Care, recently appeared by the Bob, Jesus, and I group, showing that if you set PEEP and your patient improves meaning improve clearly oxygenation, you know, that means that there is a recruitment, and this is a marker. So at the end, what it tells is that if you recruit the lung in the proper way, do not stressing the lung too much, I mean, this is a huge point for survival. This is in the Blue Journal. There is a paper that complements that one, which is they did a kind of analysis impossible to understand for me, because now you need to hire not physicians, mathematical statisticians, high level from Harvard to understand something. You know what I mean? But anyway, there is a graph saying the patients that you increase PEEP at tidal volume 6, and there is an increase in oxygenation over the time, this is a clearly marker of survival. So if you translate this in the delta pressure, I'm sure the delta pressure will go down in those patients, you know, because if you over this 10, I mean, oxygenation can increase a little bit, you know, but this delta is, and if the delta is negative, so it's poor, I mean, then it's totally. So to me, I mean, the most important thing is when we do something, do it earlier, you know what I mean, and pay attention of what's going on. Because on this table, so it's 0.5, you use 12, your oxygenation is not good, what do you do? Then increase to 18, maybe I mean, there are no clear rules for doing that, so you need to be there and to think with all this piece of information that you show us, to sit down at the bedside and you know, want to stay there during these 1, 2, or first days, which to me are critical.
I think it sort of is deciding on the best PEEP is a composite decision.
Yes,
a number of things, and I think driving pressure could be one of those things, maybe should be one of those things, but it's a composite looking at a number of things. At the end of the day, finding the best balance between recruitment and overdistension. So more recruitment causing overdistension, I think, is harmful, and not enough PEEP when we could allow more without overdistension would be harmful, if that makes any sense.
Maybe because as a point of to be aware of some tricking that happens in the real life, you can have a patient that you put a driving pressure of 15, that's okay, and you increase your PEEP. With this increase in PEEP, your compliance improves. So suddenly your driving pressure goes down to 12. So what is the next step? To increase tidal volume, because we still have some room to arrive to delta P of 15, or to remain on 12, because there you reduce opening and collapse.
So you haven't provided enough information. So is the pH 7.05 or 7.25?
I agree.
Well, you
If
show.
you need it, maybe you can increase your tidal volume. If you don't need it, just keep him like.
Yeah, I agree with that.
I know. I to increase tidal volume, are you sure? Why? Why do we need to increase tidal volume?
Why do you use 6 milliliters of your?
You are breathing at 6 mL per kilo with some
And
size.
do the same for all your ALDS patients. Without regard of they are 30% of lung collapse, 80% of lung collapse, 10% of lung collapse. So driving pressure is, as was stated in the paper, was discussed in the paper, a way to index your tidal volume to the remaining open loop. So if you are a healthier guy in the bed, you can go to a higher tidal volume without problems, because it's the same. That's lower. It's the same stress for the open lung that the lower tidal volume for a guy that has a lung with a proportion of collapse very high.
But we make compromises all along the way. So I think what I hear you saying is you would not worry about the pH because you prioritize over distinction.
Mm-hmm.
And I can accept that. Yeah.
I see. No, but I agree. I mean, the word composite, I mean, that's what I like it very much, you know. We should have all the elements of this equation in mind, and knowing physiology, and then make the decision.
Yeah, if we're not too dogmatic, we can avoid a lot of arguments.
Yes, yes.
Well, thank you very much.
Thank you.
I can hand it to the nurse, and he or she can carry it in one hand as they move it